Alright, welcome to our complete GI review for the USMLE Step 2. In this video, we're going to cover all GI concepts for the USMLE Step 2. We're going to have 200 questions on various topics, and we're going to have some awesome mnemonics along the way. Let us begin. Question 1. How is achalasia diagnosed? Achalasia, as we recall, is loss of inhibitory ganglion in the myenteric plexus of the esophagus, so patients have difficult time swallowing both solids and liquids. How is it diagnosed? With biopsy, endoscopy, or barium swallow and manometry? And the answer is barium swallow and manometry. We recall what the barium swallow looks like, that bird's beak appearance. That is pathognomonic for achalasia. And we take a look at the manometry on the right, where we see a difficult time of the lower esophageal sphincter to relax. And here we just have the other choices. Biopsy is not the correct answer for achalasia. Biopsy has very few indications for the esophagus. It's for cancer, Barrett esophagus, and eosinophilic esophagitis. Endoscopy? Nah. That's only for excluding malignancy, but that doesn't diagnose achalasia. For achalasia, we need barium swallow and manometry, again, where we see in the barium swallow the bird's beak appearance. Symptoms of achalasia include progressive dysphagia, as we mentioned, to both solids and liquids, and you could take a look at some other important facts about achalasia that I put together over here. By the way, barium swallow is the same thing as upper GI series, which is the same thing as esophagram, such fancy terms that all mean the same thing, and that's a really cool thing to know. Keep this in mind. Question 2. A 65-year-old woman complains of intermittent sudden severe chest pain. Is this a cardiac issue? No, look at the barium swallow. It's shown, and it shows the corkscrew appearance. So where do we see the corkscrew appearance? In the esophageal spasm. That's where we see corkscrew appearance, not in achalasia. Esophageal spasm is a motility disorder in which peristalsis is periodically interrupted by high-amplitude, non-peristaltic contractions, and patients present with heartburn, chest pain, but a normal EKG and stress test, dysphagia, and odonophagia, and treatment is with calcium channel blockers, TCAs, nitrates, I wrote careful over here, and you'll see later on in the video why, and PPIs in some cases. What autoimmune condition, by the way, is associated with esophageal aperistalsis? Where do we see the esophageal stop moving in an autoimmune condition? Scleroderma. Remember, CREST. What does the E stand for in CREST? Esophageal dysmotility. Question 3. A 51-year-old woman with a BMI of 41 complains of heartburn, chest pain, and dysphagia. Endoscopy reveals a hiatal hernia. What is this initial treatment? What's the initial treatment for a sliding hiatal hernia? Weight loss and PPIs are first line. Not surgery. Surgery reserved for persistence of symptoms after medication fails. By the way, there's also another type of hernia, paraesophageal hiatal hernia, which accounts for only 5 to 10% of them, that often requires surgery to prevent a gastric volvulus. And here we have a chest x-ray showing the sliding hiatal hernia, where we see it above the diaphragm. Question 4. A 34-year-old woman recently diagnosed with AIDS comes to the ED with pain on swallowing that has progressively gotten worse. The patient is not on any medications, and their CD4 count is extremely low at 39. What is the next step? And the answer is, for an AIDS patient that has esophageal infection, we want to give oral fluconazole to treat the candida, because AIDS patients that have sore throats is usually due to candida, at least in 90% of the cases, and that's why we give fluconazole for the candida, as opposed to nystatin. That's for oral candidiasis, not the esophagus, and amphotericin is second line. Question 5. What medication causes esophagitis? Alendronates, tetracyclines, NSAIDs, potassium chloride. Which of these can cause esophagitis? Pill-induced esophagitis, all of the above. And I have this fun mnemonic over here. I can't eat because I have pill-induced esophagitis. I can't. K for KCl, A for alendronates and other bisphosphonates, N for NSAIDs, and T for tetracyclines. And the treatment is to stop the offending agent. Typical symptoms of this syndrome include sudden onset odonophagia and retrosternal pain that can sometimes cause difficulty swallowing. Question 6. A 40-year-old woman complains of a burning sensation on her tongue along with difficulty swallowing. So she has a burning tongue and she can't swallow. Labs show microcytic anemia. Which of the following is associated with her underlying condition? And the answer is we're dealing with a triad in Plummer-Vinson syndrome, and therefore we see esophageal webs. Here we have the triad of Plummer-Vinson, microcytic anemia, esophageal webs, and dysphagia. Really interesting thing to point out is that the iron replacement to help the microcytic anemia can actually lead to resolution of the lesion. It's fascinating. But how do we have a mnemonic for the triad? MADE. The Plummer for Plummer-Vinson, MADE, a boo-boo, MADE for microcytic anemia, dysphagia, and esophageal web. And just to point out, this condition has an increased risk for esophageal cancer. A 51-year-old man has dysphagia, halitosis, and regurgitation of food particles. How is his underlying condition diagnosed with upper endoscopy and barium swallow? Here we're dealing with bad breath and dysphagia. That's Zenker diverticulum. And Zenker diverticulum is diagnosed with barium swallow. an outpouching or outpocketing of the posterior pharyngeal constrictor muscles. Don't do upper endoscopy. That would cause perspiration. Here we see a picture of Zenker diverticulum. And again, don't do upper endoscopy. That can cause perforation in patients with Zenker diverticulum. Question 8. After vomiting all day, a 43-year-old man vomits more, but this time bright red blood can be seen in the vomit. So he's vomiting, vomiting, then there's bright red blood. Sounds like a Mallory-Weiss tear. The patient has no pain nor dysphagia. Again, consistent with Mallory-Weiss tear, which is not a full thickness tear. What is the treatment? Orange juice? Absolutely not. That would burn like crazy. No treatment. It's self-resolving. Mallory-Weiss tear, as opposed to Borhave syndrome, is actually self-resolving in 1 to 2 weeks. If it continues to bleed, we can give epinephrine or cauterization, but in general, Mallory-Weiss tears are self-resolving. All right, here's a picture of Mallory-Weiss tear. We see it's not a full thickness tear. It's just like these, kind of like these really bad paper cuts in the esophagus. Esophageal cancer is accurately diagnosed with EGD with biopsy. We kind of mentioned this before. We want to get biopsy. Without biopsy, you can't have a diagnosis. And we get a CAT scan and ultrasound for tumor staging. As opposed to barium study, that's the best initial test, and that would show an irregular mass protruding into the lumen. Esophageal cancer can present in the upper esophagus and the lower. In the upper 2/3, that's where the squamous cell carcinoma is, and that's the most common one around the world. And that can be caused by alcohol and tobacco. Tobacco goes up. It goes up to the squamous cell carcinoma part, as opposed to the adenocarcinoma that's in the lower 1/3. That's the most common one in America and Europe. And a risk factor is Barrett esophagus. Really important is that early metastasis is seen in esophageal cancer because there's no serosa. And we must treat with chemo and surgical resection. And without resection, there is no cure. Question 10. What is depicted in the image taken during the upper endoscopy in this picture over here? GERD or esophageal cancer? And this is GERD. Esophageal cancer, we would see a mass protruding to lumen, as we could see in the bottom picture over there. As opposed to in GERD, we simply see columnar metaplasia at the lower esophagus. And here we just have some interesting points about GERD, that different causes for it, how it's diagnosed, and treatment, which includes lifestyle modification, antacids, H2 blockers, PPIs, and surgery if severe. Question about GERD, by the way, is let's say a person has GERD and he has a bad taste in his mouth and a sore throat. Again, symptoms of GERD. What's the next step? And lansoprazole, that's a PPI. That would be first line for GERD. That controls the symptoms of GERD, as opposed to cimetidine. H2 blockers aren't as good as PPIs. Antacids are not first line. PPIs are. And endoscopy is worthless for GERD. Question 11. What are causes of acute gastritis? NSAIDs, alcohol, H. pylori, toxic ingestion, and the answer is all of the above can cause acute gastritis. And here we just have some interesting points about acute gastritis. And for diagnosis, we require upper endoscopy. How do we treat acute gastritis? We stop, of course, the offending agent, for example, the NSAIDs. Antacids can help, H2 blockers. Sulfocrate may help, but it's not so helpful. Triple therapy may be required for H. pylori, ACO, amoxicillin, clarithromycin, and omeprazole. Question 12. Chronic gastritis is most commonly caused by what? H. pylori and NSAIDs cause chronic gastritis 90% of the time. And this, by the way, occurs in the antrum. I like to think ant pylori, ant for antrum, pylori, that's where H. pylori infects the stomach in the antrum, as opposed to the autoantibody parietal cells, which is 10% of the time, that's type A, that occurs in the fundus. What is the most accurate test for H. pylori? Biopsy, serology, breath test, or stool antigen. Really interestingly, biopsy. We don't often biopsy to get a diagnosis for a bacterial infection, but for H. pylori, we do. It requires an endoscopy, though, and you can take a look at the other choices, why they may be beneficial or why they may be difficult. But just remember that the breast test and stool antigen test are very sensitive and specific. They're just not as good as biopsy for making a accurate diagnosis. Question 14. An enlarged left supraclavicular lymph node is associated with which cancer? Gastric cancer. We're dealing with the GI section. It's gastric cancer, and we see that's with the Virchow node, the left supraclavicular lymph node. And there's another node that's actually associated with gastric cancer. That's the Sister Mary Joseph node. That's a palpable lymph node near the umbilicus, and we'll take a look at a picture of that over here. We see the Virchow node on top by the left supraclavicular, and the Sister Mary Joseph node by the umbilicus. And here we have just a little bit about gastric cancer as a poor prognosis because it's discovered late, usually, just like pancreatic cancer. And patients are often asymptomatic, and it's seen in Korean and Japanese, and diagnosis is with, again, upper endoscopy with biopsy. Now, if there's metastasis of the gastric cancer to the ovary, what's that called? Krukenberg tumor. You have a mnemonic. We have the Kruk for Krukenberg, and he's running towards the ovary because that's where Krukenberg tumors go. They metastasize from the stomach to the ovary. Question 15. After a meal, pain caused by gastric ulcers is greater. Gastric greater. Gastric greater. Duodenal decreased. Gastric greater. Duodenal decreased. This is in general, but you can't make a diagnosis on it. This fact is not specific enough to make a diagnosis of gastric ulcer versus duodenal ulcer. And here we just have a little bit about peptic ulcers, which includes gastric and duodenal ulcers that they result from damage to the gastric or duodenal mucosa. They're caused by impaired mucosal defense or increase in acidic gastric contents, and patients present with epigastric pain, nausea, hematemesis, melena. And the most accurate test is upper endoscopy with biopsy for peptic ulcers. What do you do, by the way, if NSAIDs are causing ulcers in a patient, but the patient needs the NSAIDs? So he needs the NSAIDs, but they're causing ulcers. What does he do? What does he do? For example, arthritis, they need NSAIDs, but they're causing ulcers. So what does he take? Misoprostol, a synthetic prostaglandin E1 that has anti-secretory and cytoprotective effects on the gastric and duodenal mucosa, and they can prevent ulcers, and that's why they're really good for a patient who needs NSAIDs. That my poor ulcer, this is a nice mnemonic, so long because misoprostol can cause ulcers to go away. They prevent the ulcers, and that's what a patient who needs NSAIDs causing ulcers can take. Question 16. A man comes in with recurring, gnawing, burning abdominal pain. He has diarrhea, nausea, vomiting, weight loss, and hypercalcemia. Always look out for these things. Why would he have hypercalcemia? What is the diagnosis? ZES or not sure? On a test, I wouldn't write not sure. I would write ZES, Zollinger-Ellison syndrome, who develop hypercalcemia in addition to these other abdominal symptoms. It's a gastrin-producing tumor in the duodenum and or the pancreas, and there's excess gastrin secretion that leads to recurrent ulcers. And the reason why there's hypercalcemia is because the association with hyperparathyroidism, such as in men type 1. All right, here we have a diagnosis of Zollinger-Ellison syndrome that the imaging shows gastric ulcers. And let's move. And what we do is we want to get gastrin levels in the body. If they're very high, we get the secretin stimulation test. There's a rise in gastrin. Even with the secretin, we know it's a gastrinoma, and we treat with high-dose PPIs and surgical resection if there's no metastasis. Question 17. A man who owns a dog, bark bark, has the following image of his liver where we see the eggshell calcification. What is the diagnosis? So of these bugs, that would be associated with Echinococcus granulosus. Echinococcus granulosus is contracted from close contact to dogs, which is the host for the tapeworm, and it causes liver cysts often found incidentally, but there may be right upper quadrant pain, and there's eggshell calcification on CAT scan. Rupture may cause anaphylactic shock. Surgical resection may often be required along with prolonged albendazole, which may work. Now, over here we just have various infectious diarrhea, their causes, and their treatments. Question 18. What is the initial test for a patient with suspected celiac disease? TTG-IgA test or biopsy? And here we have the celiac for celiac who has a gluten-free diet. So how would we initially test him? The answer is the TTG-IgA test, along with, which is a very sensitive test, and the alternative is the anti-endomysial antibody test, as opposed to biopsy, which is the gold standard, but not the initial test. Here we have a little bit about celiac disease. There's a pale, foul-smelling, bulky stools, abdominal pain, flatus, bloating, weight loss, and fatigue. 10% of patients get something called dermatitis herpetiformis, in which there are grouped papulovascular lesions on elbows, knees, butt, or posterior scalp. And treatment for celiac is a gluten-free diet. Question 19. Malabsorption, arthritis, lymphadenopathy, PAS positive granules, and lamina propria are on biopsy. What would this be indicative of? Well, PAS positive granules, pass the whipped cream. Whipple disease in which there are PAS positive granules and these other symptoms. And treatment is with long-term antibiotics a really long time. Question 20, how is lactose intolerance diagnosed? And there is a breath test. The hydrogen breath test shows increased hydrogen after ingestion of lactose. And it presents in patients with abdominal bloating, flatulence, cramping, and watery diarrhea after ingesting dairy products. And treatment is with avoidance of dairy products. And oral lactase may be given as an enzyme replacement. Question 21, what is the best initial test for carcinoid syndrome? Carcinoid syndrome is when the carcinoid tumor has progressed, metastasized to the liver, and therefore there's going to be a huge dump of hormones, including serotonin, into the blood. And therefore, how do we diagnose it? We look for that serotonin metabolite, 5-HIAA. That's how we initially test for carcinoid syndrome. Again, since this metastasized tumor releases serotonin, as opposed to a CAT scan and IN-111 octreotide scan, that's used to localize the tumor, but not the initial test. All right, here's a little bit about carcinoid syndrome. We're going to learn a little bit more about later on, including symptoms such as flushing and diarrhea and tricuspid valve lesions. But over here, I want to mention that treatment for carcinoid syndrome is octreotide and surgical resection. Question 22. What vitamin deficiency do patients with carcinoid syndrome develop? A, B3, or D? And the answer is vitamin B3 deficiency, niacin deficiency in patients with carcinoid syndrome. And the reason is as follows. The tryptophan is used to produce serotonin by the tumor cells. So they're using up the tryptophan. What's tryptophan used for? Tryptophan is used to make vitamin B3, niacin. So if we're using the tryptophan to make serotonin, tryptophan will be unavailable to make the niacin, the vitamin B3, and that's why patients will develop vitamin B3 deficiency, which includes the 3 Ds of pellagra, diarrhea, dermatitis, and dementia. Question 23, the most common cause of SBO in adults. small bowel obstruction is adhesions from a previous surgery, such as appendectomy. Hernias would be the most common cause of SBO in children. By the way, what's gallstone ileus? That type of small bowel obstruction. That's an SBO, small bowel obstruction caused by a gallstone that lodges at the ileocecal valve, and we'll talk more about this later. Small bowel obstruction, as we mentioned over here, adhesions account for 60% of them, hernias for 20%, and in partial SBO, the patient passes gas, but there's no stool, whereas in complete SBO, there's not even gas, and of course, there's no stool. Move down to the bottom, the diagnosis for small bowel obstruction would first be an X-ray, but the CAT scan would be even more accurate. All right, you can take a look at this slide over here. If there's a complete obstruction, we have to go for the exploratory laparotomy. Question 24, which condition is associated with the development of ileus? And the answer is diabetes is associated with ileus. Not hyperkalemia. Hypokalemia would be associated with ileus. Ileus is loss of peristalsis without structural obstruction, and causes include recent surgery, medical illness, hypokalemia, other electrolyte abnormalities, hypothyroidism, and diabetes mellitus. And patients present with diffuse constant abdominal pain, nausea, vomiting, and an absence of flatus or bowel movements. The best initial test is an X-ray. And in terms of treatment, bowel rest, discontinue narcotics or other drugs that reduce the bowel motility, and nasogastric suction and parenteral feeds as needed. Question 25, what is the most accurate test for mesenteric ischemia? Of course, CT angiography. That's the gold standard for arterial occlusive disease, which is what's going on in mesenteric ischemia. Maybe a CAT scan would be the best initial test, where there's air in the bowel. All right, here's a little bit about mesenteric ischemia, and I just want to mention one thing is that there's severe abdominal pain. Treatment is with volume resuscitation, broad spectrum antibiotics, and anticoagulation, and possibly resection of the infarcted bowel. Question 26, what is the most common cause of lower GI bleeds in patients older than 40? This is actually diverticulosis, not hemorrhoids. Diverticulosis is the most common cause, wow, of lower GI bleeds in patients older than 40. The second most common is hemorrhoids. Diverticulosis is an outpouching of the mucosa and submucosa that herniate through the colonic muscle layers, and it's most common in the sigmoid colon. Here we talk about risk factors. For example, a person has low fiber and a high fat diet. They're older and they have connective tissue disorders, and patients are actually often asymptomatic. It's interesting until the patient presents with sudden intermittent painless bleeding, and it can lead to diverticulitis, in which there's inflammation of a diverticulum secondary to a fecalith impaction. Diagnosis of diverticulosis is with colonoscopy and CAT scan for diverticulitis. Here we just have the diverticula by the sigmoid colon. Question 27, what is the most common outcome of large bowel obstruction? And the answer is surgery. We have to surgically correct the large bowel obstruction. And by the way, large bowel obstruction is the most common cause of is colon cancer, and therefore, if we see large bowel obstruction in a patient presents with significant distension, tympany, and tenderness, we actually have to assume it's colon cancer until proven otherwise, since that's the most common cause of large bowel obstruction. Question 28, a patient with a diagnosis of aortic valve endocarditis is given IV antibiotics. Cultures are positive for strep bovis. What is the next step? Of course, we have to do a colonoscopy because for some reason, there's this significant association between strep bovis and colon cancer. Question 29. Most patients with colorectal cancer are asymptomatic. True or false? That is true. Most patients with colorectal cancer are asymptomatic. That's why screening is so significantly important. Symptoms, though, when they do present, include weight loss, anorexia, blood in the stool, obstruction in the left side of lesions, and bright red blood in rectal lesions. But again, usually, or often, mostly are asymptomatic. Question 30. Ischemic colitis most commonly affects which side of the colon? Ischemic colitis mostly affects the left colon by the watershed area, by the splenic flexure. And it usually occurs in the setting of atherosclerosis. Patients with ischemic colitis present with lower abdominal pain followed by non-bloody diarrhea after meals, exertion, or in the heat. Fever may suggest bowel necrosis. And treatment is with bowel rest, fluids, antibiotics, surgical resection in infarction obstruction, or in fulminant colitis. Here we just see the splenic flexure. That's usually where the ischemic colitis occurs. Question 31. An upper GI bleed is classified, I meant to say, an upper GI bleed is classified as one above the colon or the jejunum above the jejunum. That's called an upper GI bleed. Under that is the lower GI bleed. So again, it's the jejunum above the jejunum. That's an upper GI bleed. Again, it's the ligament of Treitz by the duodenum. Duodenum above is an upper GI bleed. Upper GI bleeds, by the way, more often present with melena, and lower GI bleeds more with pure outright blood. That's how we distinguish between upper GI bleeds and lower GI bleeds in general. All right, and in terms of diagnosis, for the upper ones, we use the nasogastric tube and lavage, and for the lower ones, we have an endoscopy and sigmoidoscopy. But remember, give fluids before trying to figure out the etiology of the bleed, because you just got to take care of the patient before you figure out what's the underlying issue over here. Question 32. Transmural inflammation is seen in Crohn's disease. Remember, ulcerative colitis doesn't go all the way through. In Crohn's disease, it goes all the way through. Crohn's disease, we see transmural inflammation, sometimes leading to fistulas to other organs. Ulcerative colitis, I wrote the rectum is always involved, and there are continuous lesions, but they are limited to the mucosa. They don't go all the way through. And here's treatment for ulcerative colitis and Crohn's. By the way, it's so fascinating. It's such similar treatments for ulcerative colitis and Crohn's. We could, for our purposes, we could say they're basically the same thing. Sulfasalazine, mesalamine, steroids for flare-ups, immunomodulators, azathioprine, infliximab for refractory or mild to severe cases, and surgery may be required. I spelled the required wrong, I think. And in case of ulcerative colitis, total proctocolectomy or select surgical resection in the case of Crohn's disease. Question 33. Indirect hernias involve herniation of the abdominal contents, either medial or lateral to the inferior epigastric vessels, and it's going to be lateral, indirect lateral. An I looks like an L, indirect lateral, indirect lateral. I have this from my AJ Monarch's YouTube channel. I have a fun mnemonic for the different types of hernias. It's a fun one. Question 34. What condition is this triad associated with where we see fever, jaundice, and abdominal pain? So this is cholangitis. The triad that we see in cholangitis, we see fever, jaundice, and abdominal pain. And it's infection of the common bile duct, where we see, for example, a stone, but the point is that there's infection of the common bile duct. And by the way, I have a pentad associated with this, where there's also septic shock and altered mental status. You can take a look over here at the 4 different conditions and their different diagnoses, as well as their treatments. But again, acute cholangitis, which is a clinical diagnosis, and is confirmed by biliary dilation on imaging, or ERCP. Question 35. What is the treatment for gallstone ileus? Is it with reassurance or laparotomy with stone extraction? And gallstone ileus is going to be treated with laparotomy and stone extraction. Gallstone ileus must be treated surgically. Question 36. Elevated ALP and bilirubin is a sign of which of the following? Hepatocellular injury or cholestasis? So we have elevated ALP and bilirubin that would be seen in cholestasis. In hepatocellular injury, we would see elevated AST and ALT. If it's mixed, then it's a combination of both. Question 37. The most common cause of chronic viral hepatitis are HAV, HDV, or HBV and HCV, and chronic is BC. I like to think that BC was the olden days, BC for chronic, HBV and HCV. Because it's chronic, that's another one. Question 38. Which HBV serologic marker is an important indicator of transmissibility? And the answer is E, HBE, because it exits and it transmits to others. It escapes during replication. HBE, a antibody, would indicate low transmissibility because you're fighting against it. Question 39. Which value is decreased in cirrhosis? Of these values, albumin is decreased because the liver is not working, it's not producing the proteins that it needs. As opposed to the other values, they will be elevated in liver dysfunction. Right? There's an increase in bilirubin in liver dysfunction. Now note that these values are used in the initial diagnostic assessment of cirrhosis, but liver biopsy is the most accurate for diagnosing cirrhosis. Albumin, if it's below 3.5, that's a really poor prognosis. Here's a little bit about cirrhosis. There's fibrosis and nodular regeneration resulting from chronic hepatic injury. Patients may be even asymptomatic, but symptoms we'll take a look in a second, and all cirrhosis patients must get HAV, HBV, and PPSV2/3 vaccines. Here are the symptoms that we see, some of them at least. How are these different things treated? Ascites with sodium restriction, diuretics, paracentesis, and shunt. How is SBP treated? With IV antibiotics such as ceftriaxone and IV albumin, encephalopathy with lactulose or rifaximin. And how is a hepatic coagulopathy treated? FFP for acute bleeding. Vitamin K won't help. We give FFP, fresh frozen plasma, for hepatic coagulopathy. Question 40. Which value indicates that ascites is related to portal hypertension? Which is the higher value. When SAAG is bigger than 1.1, that would indicate portal hypertension. It has a high specificity and sensitivity. Examples of this would be splenic or portal vein thrombosis, cystomyosis, cirrhosis, RHF, right heart failure, constrictive pericarditis, and BCS. All of these would be indications of portal hypertension when the SAAG value is above 1.1. Question 41. Primary sclerosing cholangitis is associated with which of the following? Pianka and onion skinning or autoimmunity. It's not autoimmune. It's associated with piancas and onion skinning and with ulcerative colitis. Here's a little bit about primary sclerosing cholangitis, and we'll move to the bottom over here. Liver biopsy shows periductal sclerosing onion skinning. The MRCP, ERCP shows bile duct strictures and dilation, the beating, which we see in the picture on the right. And treatment for primary sclerosing cholangitis is ERCP with dilation, liver transplant possibly, and actually UDCA can actually help, which is the primary treatment for primary biliary cholangitis, which we'll talk about later. Question 42, which medication slows the disease progression, oh, here we go, of primary biliary cholangitis? Ursodeoxycholic acid, again, that acronym that I mentioned before. It's a cholestyramine, and cholestyramine is given for itching for pruritus. All right, here's a little bit about primary biliary cholangitis, an autoimmune condition, most common in middle-aged women. They present with jaundice, pruritus, fat-soluble vitamin deficiencies, the ADIC vitamin deficiencies, and labs include elevated ALP and a positive mitochondrial antibody. Treatment is with ursodeoxycholic acid, cholestyramine, and perhaps liver transplant. Question 43, this should have been 43, I think. What is the treatment for non-alcoholic fatty liver disease? And the answer is weight loss, diet, and exercise. Weekly phlebotomy is for something like hemochromatosis. Have this patient with hepatomegaly and there's increased LFTs, the answer is insulin resistance. That's what causes the fatty liver. Question 43, what is the most common type of primary liver cancer? And the answer is hepatocellular carcinoma is the most common primary liver cancer. It's one of the most common cancers worldwide, but it's not so common in the US. A little bit about hepatocellular carcinomas. I just will skip down to the red over here. It can involve metastasis of the lungs, peritoneum, or the bone, for example, the spine. Diagnosis is with a mass on the ultrasound, abnormal or a CAT scan, abnormal LFTs, a very high value of AFP, which is only 50% of cases actually, and get the biopsy if you're uncertain. How is primary hemochromatosis inherited? And the answer is autosomal recessive. It's characterized by mutations in the HFE gene that results in excessive absorption of dietary iron. Secondary hemochromatosis occurs in chronic transfusion therapy, such as sickle cell disease. Hemochromatosis is a state of iron overload, and there's accumulation in the liver, pancreas, heart, adrenal glands, testes, and pituitary gland, and that's why we see dysfunction or manifestations in these organs. Question 45. What does the gold stand for a patient with the following eye findings where we see these Kaiser-Fleischer rings? So this is Wilson disease, not decreased stereoplasm. We want to get the copper excretion after giving penicillamine. That's how we diagnose the gold standard for Wilson disease. Autosomal recessive disorder that results in a defective copper transport and subsequent accumulation and deposition of copper in the liver and brain, leading to psychosis and delusions. Which condition is highly malignant, insuloma or vipoma? And the answer is vipoma. Insulinoma, patients present with hypoglycemia, for example, sweating, anxiety, and headaches that resolve with correction of hypoglycemia. They get fasting lab results. We get fasting lab results, and we see elevated serum insulin, but an elevated C-peptide because there's so much internal insulin. And when it's internal, then we get the elevated C-peptide, as opposed to if someone takes exogenous insulin. And the treatment is with surgical resection of the tumor. Vipoma is very malignant. It presents with watery diarrhea, dehydration, muscle weakness, and flushing. And treatment is to replace fluids and electrolyte losses, surgery to resect the tumor, and consider octreotide. The chain of Lake's sign helps in the diagnosis of chronic pancreatitis. Because what's the pathophysiology? It represents the alternating stenosis and dilation of the main pancreatic duct on CAT scan and ultrasound, and that's seen in the chronic condition of pancreatitis. Chronic pancreatitis is the irreversible parenchymal destruction leading to pancreatic dysfunction and insufficiency, and patients may get chronic pain and pancreatic dysfunction. Courvoisier sign is associated with which type of cancer? That's pancreatic cancer, and that refers to a palpable, non-tender gallbladder. All right, here's a little bit about pancreatic cancer. Question 46, a man with C. diff is treated with vancomycin. He developed C. diff diarrhea again 2 months later. What is the best next step? The answer is treat with oral vancomycin, not IV vanco. IV vanco does nothing. You want to do oral vanco. IV vanco is completely useless because it won't pass through the bowel wall. We want to go with the oral vancomycin once again, and if it still doesn't work, then we can go with fidaxomicin. I wrote over here, then with damoxicin. Okay. Question 47. Which of the following was associated with worse prognosis in pancreatitis? Which of these is the worst prognosis of pancreatitis? The answer is hypocalcemia. Why is that? There's fat malabsorption. There's going to be extra calcium binding the fats. That's going to lead to hypocalcemia. These other values are associated with all types of pancreatitis. That wouldn't be a severe prognosis. Question 48. A 27-year-old female complains of chronic diarrhea and steatorrhea. Serum electrolytes are normal and no microbes are found in the stool. The D-xylose test is performed and the patient's urine is found to have lower than normal levels of D-xylose. What is the diagnosis? D-xylose helps us recognize malabsorption problems. So this is going to be celiac disease. We're dealing with celiac disease here. D-xylose is a monosaccharide that can be absorbed in the proximal SI, but not in patients with intestinal mucosal disease, such as celiac, due to atrophy of the intestinal villi in the proximal small bowel due to exposure to gluten in wheat. All right? As opposed to pancreatic insufficiency, that's not an absorption problem. Question 49, strict vegans may not get enough vitamin D and calcium. They get enough vitamin A and folic acid because that's in leafy vegetables, but vitamin D and calcium, even though they may be in the sun, that's only 50% of the vitamin D that they need. The other is from, for example, meats and fishes. So therefore, they're not getting enough vitamin D and calcium. Calcium is in dairy products. Question 50. A 22-year-old female complains of several months of abdominal discomfort and flatulence after eating. Omeprazole hasn't helped. So she's passing gas a lot, and omeprazole hasn't helped. She hasn't had fever or vomiting. Her abdomen is non-distended, but somewhat distended. She otherwise appears well. What is the next step? So we want to give her the lactose hydrogen breath test. This is typical. She is probably having some sort of likely having some sort of lactose intolerance. Question 51. A patient, a 59-year-old male from Mongolia, complains of mid-epigastric pain that doesn't change with food intake. He has nausea, vomiting, and weight loss. So we're probably dealing with cancer here. Hepatomegaly is noted on palpation, and labs show microcytic anemia, slightly elevated liver enzymes, and hypoalbuminemia. What is the most likely diagnosis over here? So over here, we're dealing with a gastric cancer. It's the greatest risk in Eastern Asia and Eastern Europe because of their diet, and nausea and vomiting due to stomach obstruction. We're going to take a look at the other choices in a moment. Let's just take a look at this thing about gastric cancer. It usually presents late in the disease, as we mentioned, and by that point, it's big enough to cause epigastric pain, weight loss, and dysphagia, nausea, and vomiting. The tumor vessels often leak into the stomach lumen, and so many patients develop iron deficiency anemia. And tumor metastasis may occur to the liver. That's why patients develop hepatomegaly and the elevated enzymes and hypoalbuminemia. As for the other choices, well, I want to focus on pancreatic cancer. There would be more of an epigastric pain as opposed to mid-epigastric, and there would be hyperbilirubinemia and jaundice. That's why this question over here points in the direction of gastric cancer. Question 52. A 35-year-old woman with a history of HIV at 29 weeks gestation presents with elevated transaminases but normal ALP. Her hepatitis C screen and syphilis were negative at her first prenatal visit. Vital signs, including blood pressure of mom and baby, are normal. What is the next step? So here, even though she was negative at her first visit, she still may be positive for viral hepatitis, because she could have gotten it during the pregnancy, especially since she has a history of HIV. She uses needles a lot, so therefore, it's likely that she's contracted hepatitis C virus, and that's why she's had these elevated transaminases. Urine protein collection would be to evaluate for preeclampsia, but here she had normal blood pressure. Question 53. A smoker has weight loss, fatigue, anorexia, and jaundice. Ultrasound reveals that the common bile duct is dilated. This presentation is most consistent with pancreatic cancer. Again, weight loss and the common bile duct dilation due to obstruction. Tumors in the pancreatic head often compress the pancreatic duct and common bile duct, leading to jaundice. And here's a little more about findings in pancreatic adenocarcinoma. Weight loss is seen in 90% of patients, abdominal back pain in 80%, and you could take a look at these other statistics. But remember, although CA19-9 is often elevated in pancreatic cancer, it's not used as a screening tool. It's helpful in monitoring disease progression. Question 54. A 29-year-old diabetic woman at 15 weeks gestation complains of nausea. She denies vomiting or abdominal pain, and her sclera are not jaundiced. Okay, so she's got this nausea, vomiting, and abdominal pain. ALP is a little high, 145. AST is 113. ALT is 130. Ultrasound of the right upper quadrant shows some gallstones, but no thickening of the gallbladder wall. Okay, so there's some gallstones, but no thickening. The common bile duct is normal. What is the diagnosis? What's going on over here with this diabetic woman who's pregnant? What's going on? She's got non-alcoholic fatty liver disease. That's what's going on over here. I wrote on the bottom over here that risk factors are diabetes, obesity, and dyslipidemia. And what happens is there's an unregulated production of triglycerides in the liver, which deposit as fatty acid in the liver, leading to steatosis. Most patients are asymptomatic. Some have slight right upper quadrant pain. As fat builds up, it can lead to liver fibrosis and cirrhosis. Treatment is with weight loss to reduce the fat deposition in the liver. Question 55. The doctor, while reading a CAT scan of a 35-year-old woman, incidentally finds a small mass in the liver that is solitary, well subscribed, and has a central stellate scar. What is the diagnosis? If you hear the word central stellate scar, you'll probably have no idea what it's talking about. Just remember that it's focal nodular hyperplasia. Focal, as you can remember, central stellate scar for focal nodular hyperplasia, which is a benign regenerative liver nodule, commonly in women from the ages 20 to 40. It's mostly asymptomatic, but it's usually found incidentally, and treatment is rarely required. Question 56. During an episode of a benign syncope, a 9-year-old boy fell onto his abdomen. He complains of postprandial abdominal pain and vomiting over the next 2 days. Wow. PE shows, physical exam shows epigastric tenderness. Bedside ultrasound shows no free fluid, but radiograph shows gastric dilation. What is the diagnosis in this case over here? This is a duodenal hematoma. That's why he has all this pain. That's why he's vomiting. That's why there's no free fluid, because nothing was lacerated. There's just a hematoma. In liver laceration, It would be free fluid. Question 57. A 52-year-old male with months of fatigue and joint pain comes in due to progressive abdominal pain. He admits to fevers, weight loss, and headaches. CT angiogram shows bilateral renal infarcts and several microaneurysms of the abdominal arteries. What is the diagnosis? This question really needs to ring bells in our mind of polyarteritis nodosa. Again, microaneurysms of the abdominal arteries. That's what we see in polyarteritis nodosa, which is a systemic vasculitis of medium-sized vessels, arteries, causing transmural inflammation of the arterial walls. Patients can present with fever, joint pain, tissue ischemia, affecting primarily the kidneys, but also other organs, such as the GI tract leading to abdominal pain and microaneurysms, which we can see over here, the abdominal microaneurysms. Question 58. Persistent bloody ascites on multiple diagnostic parentheses would be most indicative of? This would be hepatocellular carcinoma that could present with persistent bloody ascites. In nephrotic syndrome, we see straw yellow ascites, and in SBP, we see cloudy ascites. And in portal vein thrombosis, we don't see ascites. 59. A 55-year-old woman develops abdominal distension several days after surgery. Temperature is 98.8. Bowel sounds are decreased. Imaging shows diffuse colonic dilation, but no obstructions. Everything's dilated. There's no blood in the stool. Everything's dilated. What's going on over here? Ogilvy syndrome. Ogilvy syndrome is when everything is dilated. It's called acute colonic pseudo-obstruction. There's no obstruction, but for some reason everything is dilated. And treatment is bowel rest, colonic decompression, and IV neostigmine if no improvement. Here we have this ogre over here saying, give me that. Give me that. The ogre will give me that pseudo-obstruction. It's ogre saying, give me. For Ogilvy syndrome is when there's the pseudo-obstruction. That's why this ogre over here is trying to get the pseudo-obstruction poster. Question 60. A 40-year-old woman presents with months of jaundice and weight loss. Aminotransferases are slightly elevated and ALP is 890, really high. What is the most likely diagnosis? So here we have jaundice, weight loss, and ALP being 890. That's malignant biliary obstruction. Elevated ALP out of proportion to the transaminases suggests intrahepatic cholestasis or biliary obstruction. So this plus the weight loss points to the direction of malignancy. For example, a pancreatic adenocarcinoma or cholangiocarcinoma causing obstruction. Question 61. A little girl takes the over-the-counter medication for fever, which resolved, but now soon develops nausea, vomiting, hepatomegaly, and cerebral edema. What is the mechanism? So this sounds like Rye syndrome. Rye syndrome is due to mitochondrial dysfunction. And remember, only give aspirin to kids in Kawasaki disease and rheumatologic diseases such as juvenile idiopathic arthritis. Question 62. A 7-month-old baby with a history of abdominal surgery soon after birth presents with chronic symptoms of episodic bilious vomiting, abdominal pain, irritability, and inconsolability. Bowel sounds are normal. Stool is negative for blood. What is the most likely diagnosis? So here, he's vomiting a lot, he has abdominal pain, and he's in a really bad mood. That's volvulus. Volvulus is a common cause of bilious emesis in infants, especially those with other congenital anomalies such as omphalocele or adhesions. Chronic episodic symptoms can occur with intermittent volvulus, and acute volvulus is a life-threatening emergency. Diagnosis with an upper GI series. Treatment, again, is with surgery. Pyloric stenosis and food protein-induced enterocolitis is non-bilious vomiting, as opposed to intestinal malrotation that will lead to a bilious vomiting. All right. And we just have a picture of the intestinal malrotation. If you see this x-ray in a patient who's hemodynamically unstable, just get to surgery right away. This is a huge emergency. Laparotomy you have to do right away. Question 63. A 39-year-old woman ingested acid to commit suicide 3 months ago after finding out she was diagnosed with diabetes. Now she develops early satiety, nausea, non-bilious vomiting, and weight loss. So she's developing all these symptoms after trying to commit suicide with acid. What's the cause? That's a pyloric stricture. Pyloric strictures, as you can see in the picture over here, this fibrosis that builds up weeks after an ingestion of something. Diagnosis with upper endoscopy, and treatment is with surgery. Diabetic gastroparesis wasn't the right answer because that usually presents 10 years later. The lady in our question over here developed it 3 months later. That's more in the direction of pyloric stricture. Question 64. A patient with cirrhosis develops confusion asterisk should be treated with lactulose. We saw lactulose. The mechanism is that it lowers ammonia in hepatic encephalopathy, as opposed to dantrolene that's used in neuroleptic malignant syndrome. I meant to make that an M. And in malignant hyperthermia. And chlordiazepoxide, that's a long-acting benzodiazepine for alcohol withdrawal. Question 65. A 40-year-old woman complains about gastric pain and diarrhea. Physical exam shows abdominal tenderness. Endoscopy reveals gastric folds and several duodenal ulcers. What is the next step? So here we're talking about serum gastrin level because we want to check for Zollinger-Ellison syndrome. That's why she has these several ulcers and the epigastric pain and the gastric folds. This is all seen in Zollinger-Ellison syndrome, so we want to get a gastrin level. As opposed to H. pylori, that's triple therapy that treats H. pylori, and that could cause gastric duodenal ulcers. However, diarrhea and multiple ulcers in different sites are much more suggestive of the Zollinger-Ellison syndrome gastrinoma. Question 66. A woman in her third trimester has epigastric pain, radiating to the back. Lipase is 530, really high. She doesn't drink, and gallstones are excluded. She has a history of hypertriglyceridemia. What is the next step? So here, she likely has triglyceridemia-induced pancreatitis. So we want to get a lipid panel, which is required for diagnosis. Let's take a look at other choices. Antibiotics has no benefit in acute pancreatitis. CAT scan, we don't need that because we already have epigastric pain and lipase levels. 2 out of 3 is enough to make a diagnosis of acute pancreatitis. Question 67. What is the treatment for an asymptomatic biliary cyst? It's actually surgery due to the concern for malignancies such as cholangiocarcinoma or gallbladder cancer. Question 68. 55-year-old woman, obese woman, develops mild hepatomegaly with AST 84 and ALT 94. She has diabetes and is taking metformin and atorvastatin for years. What is the diagnosis? She's this hepatomegaly. What's going on over here? So once again, we have non-alcoholic fatty liver disease, which is seen more in obese patients. Patients present with hepatomegaly and elevated ALT and AST, and we treat this condition with weight loss and diet. Question 73. All patients with cirrhosis should undergo which test? They all should get an endoscopy because we want to look for varices. That could be really dangerous. CAT scan is unnecessary. Question 74. If EG reveals some varices, what's the next step? We want to give non-selective beta blockers such as propranolol or nadolol or endoscopic variceal ligation. That's the patient's choice, but they both could prevent the varices from leading to severe bleeding. Question 75. A pregnant woman in her third trimester has mildly elevated aminotransferases, hypoglycemia, and thrombocytopenia. She is normotensive. What is the best treatment? So this over here is acute fatty liver of pregnancy. That's why we see hypoglycemia and thrombocytopenia, and therefore the treatment is immediate delivery. Magnesium is for preeclampsia. All right, question 76. A patient with Tylenol toxicity has rising serum bilirubin levels and PT levels. So here we're dealing with acute liver failure. What's the next step? So here, since the liver is heading in a really bad direction, we have to send for liver transplant. Question 77. Spider angiomas and pulmonary erythema in cirrhosis are due to which of these? And the answer is estrogen. It's quite interesting. Estrogen. How does this work? Well, there's impaired hepatic metabolism of circulating estrogens leading to hyperestrogenism, right? Because usually there's hepatic metabolism of estrogen, but since the liver is not working, there's going to be increase in estrogen leading to gynecomastia and testicular atrophy. Circulating estrogens affect vascular dilation as well, and that explains the spider angiomas and the pulmonary erythema. So again, in cirrhosis, there's going to be impaired hepatic metabolism, and that's why there's going to be impaired hepatic metabolism of circulating estrogens. That's why patients have female symptoms. Question 78. A relatively asymptomatic man has hepatosplenomegaly, elevated LTs, hypercalcemia, and highly lymphadenopathy. What is the diagnosis? This should ring bells in our mind of sarcoidosis. Right, sarcoidosis is a multisystemic inflammatory disease involving non-casing granuliomas, asymptomatic liver involvement with LFTs and hepatomegaly. That's common, but even more common is lung involvement, more than 90%. Hypercalcemia results from vitamin D conversion by macrophages in the granulomas. Question 79. What is the proper treatment or management for a button battery lodged in the esophagus of a baby? Endoscopy. Bronchoscopy would be for a trachea, an aspirated object. Endoscopy is for a button stuck in the esophagus. The same would be true for any sharp object such as fish bone found in the esophagus, stomach, proximal duodenum, or in the case of two magnets. Two magnets are also really dangerous. We have to get rid of them due to the risk of bowel entrapment. Question 80. A 2-year-old with impaired adaptation to darkness, photopia, and dry scaly skin likely has which vitamin deficiency? So which vitamin deficiency presents with these? That would be vitamin A. Vitamin A is for the eyes, and therefore if you don't have it, it can lead to photopia as well as dry skin and by toe spots, and you could take a look at what vitamin B2 and vitamin C deficiency would cause. Question 81. A 7-year-old woman with atherosclerosis presents with crampy postprandial epigastric pain, food aversion, and weight loss. What is the underlying mechanism of most likely diagnosis? So what's going on over here? Why is she getting this crampy postprandial epigastric pain? The answer is she has atherosclerosis of the mesenteric arteries. This is chronic mesenteric ischemia, and there may also be nausea, diarrhea, and an abdominal bruit in 50% of cases. But that's why she has this weight loss and epigastric pain, because of the chronic mesenteric ischemia. Question 82. An elderly lady presents with conjunctival pallor. Which medication may have caused this? So which one causes pallor? Aspirin and naproxen can cause an underlying anemia. Concurrent NSAID and aspirin can cause gastritis and or ulcers, leading to the GI blood loss and depletion of iron stores. That would lead to conjunctival pallor. 83, a 65-year-old woman has early satiety, nausea, abdominal distension, and intractable vomiting. He also has hypokalemia and new onset hyperglycemia. Why is he getting hyperglycemia? What's the most likely diagnosis? Pancreatic adenocarcinoma. He's getting hyperglycemia due to the destruction in the pancreas, islet cell destruction as the tumor invades the pancreas. Gastric episode is, I don't know how to pronounce it, is when there's ingestible material in the stomach. That's very rare, but that's not what's going on over here. Question 84. A pregnant woman is found to have an elevated AFP on second trimester screening. Ultrasound shows a fetus with thickened intestinal loops floating free in an amniotic fluid. So there's free intestines floating around. That's seen in gastroschisis as opposed to an omphoceal, prune belly. That's a prune belly triad. One of them is omphoceal. There, it's covered up. It's not going to be free floating, but gastroschisis is a full thickness abdominal wall defect where we're going to see things floating around. Treatment is generally with surgery. All right, here we see the difference between omphoceal and gastroschisis. Again, in gastroschisis, we see it floating around. Question 85. Distant infection, such as endocarditis, high fever, and tender splenomegaly. What's going on in the spleen? Of course, we have a splenic abscess. It's a rare, potentially fatal complication of bacteremia, for example, from endocarditis. The risk is greatest in immunocompromised malignancy or diabetes. Patients usually have persistent fever and the left upper quadrant pain, because that's where the spleen is, and treatment is with antibiotics and splenectomy in some cases. Or maybe most cases. Question 86. A baby has these findings. Macroglossia, lateralized growth. It's like more on one side. What's that? What should be done? The answer is abdominal ultrasound, because he might also have Wilms tumor. This is Beckwith-Wiedemann syndrome, where we see the macroglossia lateralized growth, and we could also have a Wilms tumor. That's why we have to get an abdominal ultrasound. Question 87. A man has dysphagia to solids but not liquids. He feels like food gets stuck in his throat. What's the next step? We already mentioned this. Endoscopy. First step in assessing suspected mechanical obstruction would be malignancy. Manometry would be if there's like achalasia, but that would be to both solids and liquids. The fact that there's dysphagia to solids but not liquids makes us think that this is more of a malignancy. Okay. Question 88. A pregnant lady presents with right-sided abdominal pain with rebound and guarding, fever and mild leukocytosis several days after a C-section. What's the diagnosis? This is likely an appendicitis. Appendicitis in pregnancy can have really weird presentations. It can even go up to the right upper quadrant. That's important to keep in mind. Here we just look at the other choices. Septic pelvic thrombophlebitis is rare. It's associated with endometritis. In endometritis, there's fever and lower abdominal pain. Also uterine tenderness, purulent lochia, and heavy vaginal bleeding, which we didn't see in this patient. And there would be no rebound and guarding because the infection is contained in the uterine cavity. Question 89. A toddler with constipation and normal growth should be treated with polyethylene glycol. That's Miralax. He should be treated with Miralax for his constipation as opposed to loperamide. That's an anti-diarrheal agent. That would make a person even more constipated. Question 90. A 26-year-old woman has episodic gastric pain. The pain which wakes her up at night is relieved by some food and water. She has no significant medical history and takes no medication. She admits to drinking alcohol and smoking pot. After confirmation of the diagnosis, what's the best step? Stop alcohol, stop pot, omeprazole, or antibiotics and pantoprazole? The answer is antibiotics and pantoprazole, because she has a duodenal ulcer. The majority of these ulcers are due to H. pylori NSAIDs, but she wasn't taking any meds. So we confirmed the diagnosis of H. pylori with urea breast test or endoscopic biopsy. Management of this involves antibiotics, as we mentioned, amoxicillin, clarithromycin, and a PPI, omeprazole, ACO, A for amoxicillin, C for clarithromycin, and O for omeprazole. 91. An elderly patient has vague left lower abdominal discomfort, anorexia, and constipation. He experiences a sudden severe episode of abdominal pain, followed by fever and peritonitis. Free air is seen on an abdominal imaging. What happened? So what happened? He had this pain, and now he has free air. That is a diverticular perforation, which is a classic presentation where there's free air on abdominal imaging. Question 92. Which diagnostic markers are most appropriate to diagnose acute hepatitis B infection? HBS, AG, and IgM. That would be in the acute phase. All right, the first serologic marker to appear in the serum is HBV, followed by IgM, which is when the clinical symptoms appear, and elevation in the aminotransferases. Question 93, a 7-week-old healthy baby strains when pooping. The stool has normal consistency. What's the next step? So here we want to give reassurance, because here we're dealing with infant dyschezia, is a common benign self-resolving functional disorder in which the baby cries and strains before pooping. Okay. Question 94. Sepsis, which involves fever, hypotension, and confusion 10 days after admission for acute pancreatitis, warrants, what are we going to do over here? CAT scan of the abdomen, because we have to look for infected pancreatic necrosis, which we treat with antibiotics and debridement. All right. Question 95. A patient who underwent Roux-en-Y gastric bypass several months ago develops nausea, postprandial vomiting, GERD, and dysphagia to solids and liquids. So this is a complication of the gastric bypass. What's the next step? So here we want to get an EGD because here we're dealing with a stromal, what's it called? A stomal stenosis. Stomal stenosis is a complication of Roux-en-Y. It occurs in the first year and it involves narrowing of the GJ anastomosis. Diagnosis, as we mentioned, is with EGD, during which balloon dilation can be performed to open the narrowed gastric pouch outflow. That's the answer over here. Question 96. A patient develops fever, fatigue, weight loss, and severely elevated aminotransferases above 2,000. What's the diagnosis? Over here it's hepatitis A infection. Hepatitis A infection has an abrupt onset fever, fatigue, anorexia, severely elevated aminotransferases, usually followed by jaundice and pruritus within 2 weeks. Treatment is supportive, and there's post-exposure prophylaxis, vaccine, and the immunoglobulin to close contacts, as opposed to, if you look on top, acute cholangitis, there the patient would be very sick. There would be elevated LP, but ALT and AST would not be significantly elevated. Question 97. A child develops rapid encephalopathy and liver failure, as well as elevated pneumonia. No jaundice is noted. What should be assessed for to obtain a diagnosis? So we spoke about Rye syndrome before. There's likely a Rye syndrome going on over here. A child adverse reaction to aspirin, medication history. There's a mitochondrial dysfunction which leads to hepatic dysfunction, and ammonia accumulates, leading to astrocytedema and these other neurologic problems. The child could die. Question 98. A patient presents with melanoma, right upper quadrant pain, jaundice anemia, and hyperbilirubinemia after a recent liver biopsy. Wonder what happened during the biopsy. Sounds like something bad. Hemoglobin's really low. What's most likely diagnosis? So it sounds like the person is bleeding from the biopsy. Hemophilia involves bleeding into the biliary tract, and the patient presents with right upper quadrant pain, jaundice, anemia, and hyperbilirubinemia, especially several days after a procedure like a liver biopsy or cholecystectomy, or due to tumor or trauma. Question 99. All breastfed infants should receive vitamin D? Yes, because there's no vitamin D in breastfed milk. Okay. Question 100. Patients with a history of cirrhosis and ascites develops fever, lethargy, and mental status changes. What should be done next? So again, he has cirrhosis and ascites and has all these problems. We want to get a paracentesis to look for SBP, which is a really severe condition. Barometer is used to assess the colon. Laparoscopy is not necessary for the diagnosis. All right. So here we talk a little bit about SBP. And all the way in the bottom, we see that enteric organisms are E. coli and Klebsiella are the most common ones, and we treat the patient with SBP with third-generation cephalosporins, such as ceftriaxone. Question 101. A woman on chemotherapy develops voluminous watery brown diarrhea that persists despite not eating. Stool tests are negative for fecal occult blood, and C. diff leukocytes are normal. What is the best next step? So over here, she's just having this watery brown diarrhea, so we give her loperamide to stop the diarrhea, right? You could take a look what the other things are caused, but loperamide is an antidiarrheal. And of course, we want to give her oral hydration. And by the way, diarrhea is common with chemotherapy, such as with fluorouracil, due to the direct cytotoxic effects on the intestinal mucosa, so we want to give loperamide. Question 102. What is the mechanism of GRD-induced diarrhea? It's local epithelial destruction. There's disruption of the epithelial tight junctions between small intestine and enterocytes, leading to malabsorption, non-bloody, foul-smelling, oily diarrhea that can occur 1 to 2 weeks after exposure. Question 103. Acute pain and tenderness in the left upper quadrant, nausea and fever in a patient, and he had an embolism or thrombosis. This is a splenic infarction, and note the wedged-shaped splenic infarction over here. Most cases arise due to either thrombosis, embolism, or hemoglobinopathy. Question 104. A person undergoes surgery and several days later develops right upper quadrant pain, fever, and leukocytosis. Imaging shows a distended gallbladder with no gallstones. What's the diagnosis? Here we have a calculus cholecystitis, which results from gallbladder stasis and ischemia, which then causes a local inflammatory response in the gallbladder wall, and it's seen in patients with trauma, surgery, illness, or prolonged fasting. Treatment is with antibiotics and percutaneous cholecystomy, i.e. drainage, and cholecystectomy once the patient's medical condition improves. Question 105. Painful erythema nodules on the shins is most associated with, so this is erythema nodosum. This is seen in IBD. All right. It worsens during IBD flares. Question 106. A pregnant woman presents with hematochezia, abdominal pain, and tenesmus, fecal urgency followed by straining and inability to defecate. The most likely diagnosis is this is seen in irritable bowel disease, i.e., well, one of them, ulcerative colitis. Pregnancy can worsen ulcerative colitis due to placental cytokine colonic inflammation, leading to severe hematochezia and anemia. As opposed to internal hemorrhoids, that's very common also in pregnancy, but it prevents with streaky bloody stools in the setting of constipation. It would not explain tenesmus. Question 107. A patient in ICU for several days develops an occult GI hemorrhage. He has no abdominal pain, nausea, vomiting, hematemesis, diarrhea, or hematochezia. So why is he getting a GI hemorrhage? And this is due to stress-induced ulcer, seen in patients who were in the ICU. Develops within hours to days of severe physiological stress. It's multifactorial. Stress ulcers typically form in the proximal stomach and the duodenum. They may have painless GI bleeding. Treatment is with PPIs and close monitoring. Endoscopy if there's a significant bleed. Question 108. Porcelain gallbladder is a risk factor for You just got to know this. You see the porcelain gallbladder in the image. Gallbladder adenocarcinoma. Porcelain gallbladder describes the calcium-laden gallbladder wall with brittle consistency. The pathogenesis is unclear, but it's associated with acute cholecystitis and 4% risk of adenocarcinoma. Therefore, we consider cholecystectomy even if the patient is asymptomatic, but especially if they're symptomatic. All right. Question 109. A woman presents with scleral icterus and hyperbilirubinemia and a positive urine bilirubin assay. Her symptoms are intermittent and her LFTs are otherwise normal. Liver biopsy shows dark granular pigment accumulation within the hepatocytes. What's the mechanism of her illness? So if you see dark granular pigment accumulation in the hepatocytes, that is pathognomonic for Dubin-Johnson syndrome, and that is impaired hepatocyte bilirubin excretion. She can't get rid of her bilirubin. That's what we have over here. It's a benign hereditary hyperbilirubinemia called Dubin-Johnson syndrome. And again, the liver biopsy shows grossly black liver and dark granular pigment accumulation in the hepatocytes, but that's not required for diagnosis. Question 110. If there's a concern that a patient may have a post-bariatric surgery anastomotic leak, they have fever, severe epigastric abdominal pain unrelated to eating and worsening intensity over time, the next step would be we want to get a CAT scan because we're going to have to go with emergency surgery if this really is the case, because it's severe mortality if this is not treated. On question 100, this should be 111. Several days after undergoing laparoscopic appendectomy, a woman develops fever, abdominal pain, and vomiting. So she had this appendectomy, and now she's getting all these symptoms. Leukocyte count is 25,000. What's the diagnosis? So this is actually a subphrenic abscess. Subphrenic abscess is a complication of appendectomy, especially with laparoscopic appendectomy, and the diagnosis is with CAT scan, and treatment is with drainage and antibiotics. Question 111. What do these labs indicate? Where a person is anti-HBs and anti-HBC positive? That's a resolved HBV infection. That's why they have the antibodies against these HBs and HBC. Question 112. Screening colonoscopy should be offered to patients with ulcerative colitis at 8 years after diagnosis, and then actually pretty often, every 1 to 3 years, right? Because due to the increased risk for colorectal cancer. Every 5 years would be for people without ulcerative colitis, but severe risk factors, such as a first-degree relative who got it before the age of 60. Question 113. A patient presents with fever, jaundice, and right upper quadrant pain. That sounds like acute cholangitis. ALP and bilirubin are elevated. Which finding is associated with this diagnosis? We know this already. Raynaud's pentad, where we also have altered mental status and hypotension. 114. First-line treatment for mild ulcerative colitis limited to the rectosigmoid is mesalamine enema. Here we just have a chart of mesalamine enema. So again, mesalamine and sulfasalazine are for mild ulcerative colitis, where there's less than 4 watery bowel movements a day. And TNF-alpha inhibitors is first line for moderate to severe, where we see more than 6 bowel movements a day, frequent hematochezia, anemia, and elevated inflammatory markers. Question 115. Fascial dehiscence with potential evisceration is managed with emergency surgery because we have to be worried about herniation and strangulation. In 116. Treatment for actively bleeding esophageal varices in a patient involves hemodynamic support, prophylactic antibiotics, and we want to give octreotide. Octreotide is a somatostatin analog. It leads to vasoconstriction, so it stops the bleeding, as opposed to these other things. You can take a look at what they're used for. Packed red blood cells, as you see in choice D, that's if the hemoglobin is below 7. Here it was at 10. All right, octreotide. How do you prevent varices again? That's with beta blockers. Question 117. Symptomatic anemia with macrocytic red blood cells, hypersegmented neutrophils, and normal methylmalonic acid levels are seen in, well, if they're normal methylmalonic acid, we know it's folate, because in cobalamin and in B12, there's going to be not normal methylmalonic acid levels, right? It would be high. Question 118. An 8-year-old boy has a family history of colon polyps and a germline mutation to adenomatous polyposis coli tumor suppressor gene. What's the next step? So we don't do a protocolectomy. We wait until he's older. Right now, we just do frequent colonoscopies, right? We wait till he's in the late teen years, unless there's severe dysplasia. Question 119. A woman with a history of cervical cancer treated with radiation therapy now has hematochezia. So she had radiation, and now she has hematochezia. Colonoscopy reveals mucosal pallor, friability, and telangiectasias confined to the rectum. What is the diagnosis? We have telangiectasias confined to the rectum. That's radiation proctitis, and there's actually acute and chronic form. In the chronic one, we see the telangiectasias and the bleeding. This all occurs due to damage to the rectal epithelium associated with the radiation. Question 120. A 34-year-old woman presents with 4-month history of intermittent retrosternal pain. Episodes last 10 minutes and are instigated by stress and cold and hot food. ECG is normal. Sublingual nitroglycerin alleviates some pain, but a stress test does not produce symptoms or abnormal EKG changes. So we know it's not a cardiac problem. Upper GI is unremarkable. What's the next step? So here we're trying to figure out why she has these episodes. This sounds like an esophageal spasm, in which case we want to get esophageal motility studies, again, to assess for a diffuse esophageal spasm. Nitrates why do nitrates help over here? It says to alleviate the pain. This is really cool, and I mentioned this at the beginning of this lecture. They not only relax myocytes, but also smooth muscle cells in the esophagus, and that's why they can relieve pain in esophageal spasm. Question 121. A man sustains BAT, blunt abdominal trauma, during a car accident. CAT scan reveals the following. What's the next step? So here we have free air, and therefore we want to go with surgical exploration. I'm going to show you. Over here we see the free air and peritoneal lavage. Then there's no need because there's clear evidence of a GI perforation. Question 122. A 63-year-old woman complains of 3 months of constipation and crampy left lower abdominal pain. The pain is not affected by bowel movements. She doesn't have a history of constipation. What's the next best step? So over here, she's 63 already. So the fact that she's developing constipation now is concerning, and therefore we want to get a pelvic ultrasound. Polyethylene glycol or Miralax would not simply be enough because here we have concerning features. Question 123. A pregnant woman in her third trimester has elevated total bile acids, elevated aminotransferases, and pruritus that is worse on her hands and feet. At 37 weeks, it is discovered that the fetus has no cardiac activity. Platelets are 140,000. What's the diagnosis? So here we have intrahepatic cholestasis of pregnancy, in which happens in the third trimester because of increased estrogen and progesterone leads to decreased bile excretion, increase in bile acids which accumulate in the liver, leading to an aminotransferase elevation, skin pruritus. Bile acids can cross the placenta and potentially lead to fetal demise. Question 124. Can a lady on methadone maintenance therapy breastfeed? The answer is yes. Contraindications include tuberculosis, HIV, herpetic breast lesions, varicella, chemo, radiation therapy, active substance use disorder, and galactosemia in the infant. And you could take a look at this video on my YouTube channel about breastfeeding contraindications. Question 125. A 4.1 centimeter multilocular cyst is found incidentally in the head of the pancreas of a man. The main pancreatic duct is somewhat dilated. What's the next step? We want to go with biopsy because it's pretty big. It's concerning when they're bigger than 3 centimeters, or they're irregular, or if there's main pancreatic duct involvement. Question 126. What's the initial management of uncomplicated hemorrhoids? We want to go with high fiber diet and follow up. So hemorrhoid diagnosis is based on clinical findings, but endoscopy is helpful in using if they are not palpable on exam. Initial management includes increased fluid and fiber and reduction of fat and alcohol. Colonoscopy only if there's rectal bleeding or concern from malignancy. Topical nifedipine is to reduce anal sphincter pressure in patients with anal fissures, which are severely painful, and they sometimes bleed. Question 127. A patient with ulcerative colitis develops 2 days of abdominal cramps and voluminous water diarrhea several times a day. What's the next step? So he has ulcerative colitis and getting watery diarrhea. So there's not really an ulcerative colitis problem. We would see bloody diarrhea there, and therefore this might be a C. diff problem. We're going to go stool testing for C. diff, okay? TNF-alpha therapy is for refractory ulcerative colitis, which would cause small volume bloody diarrhea. Question 128. A 25-year-old thin female has frequent watery bowel movements. Labs show hypokalemia and metabolic acidosis, a dark brown discoloration of the proximal colon seen on colonoscopy, which will be positive in this patient. It's positive stool laxative screen. She's taking laxatives because she wants to stay skinny. That's why we have this. It's called factitious diarrhea. That's why it's hypokalemia, because she's having diuretics. Amelonosis coli is often seen in these patients on colonoscopy, where they have dark brown discoloration of the colon with pale patches of lymph follicles. Question 129. What's the diagnosis of this 1-day-old baby? We have the triple bubble. That's jejunum, and therefore we're going to have dilation of 3 different organs. As opposed to in duodenal atresia, we have the double bubble sign. Only 2 organs are going to be large. Question 130. Which form of nutrition is optimal for severe burn injury patients? And the answer is enteral. We don't want to go with IV. Enteral is preferred because it's associated with multiple clinical benefits, including maintenance of gut integrity, reduced rates of sepsis and infections, and decreased mortality. Question 131. A man gets crushed by a motorcycle. He now has hypovolemic shock, and he has fractures on each side. What's the most likely diagnosis? So he has severe hypotension. He's lost lots of fluid. It's not going to be a duodenal hematoma because there we don't have free fluid flying. It's going to be a liver laceration. Liver laceration is frequently injured in BAT, and it leads to loss of lots of fluids of blood, and therefore there's going to be severe hypotension, hypovolemic shock. And in splenic hematoma, rapid compensation again is uncommon. Question 132. Alcoholic liver hepatitis. What are the lab values? They're not going to be so high. They're going to be always under 500. AST is going to be 235, ALT is going to be 110, and GGT is going to be elevated, always less than 500. Question 133. What's the mechanism of physiologic jaundice? And it's going to be low UGT activity levels. What happens at birth is that there are fetal red blood cells that are increased with a shortened lifespan. That results in a really high red blood cell turnover and high bilirubin production. Hepatic bilirubin clearance is decreased because of decreased UGT activity, and therefore there's going to be an elevation of bilirubin, and therefore there's going to be jaundice. Question 134. A 40-year-old woman has had 2 days of abdominal pain, nausea, and vomiting. She hasn't pooped or flatulated in 3 days. Temperature is 102, blood pressure is low, the abdomen is distended, bowel sounds are decreased. What is the next step? So what's going on over here? She says abdominal pain, nausea, and vomiting, and she hasn't pooped or flatulated, and she has fever. This is going to be, we want to go with urgent surgery because this, we are concerned of a small bowel obstruction with hemodynamic instability. It's progressed beyond simply the obstruction. A woman on long-term NSAIDs had suspected peptic ulcers. She now has fever and signs of peritonitis. What's the next step? So here we want to get an x-ray of the chest and the abdomen, and the reason is to look for free air because peptic ulcers that leads to peritonitis were concerned about a perforation. 136, a woman has recurrent abdominal pain and dyspepsia sometime after her cholecystectomy. Her LFTs are elevated and an abdominal ultrasound shows a mild dilatation of the common bile duct. What's the next step? So she had a cholecystectomy and now she has dilation of the common bile duct. Here we want to go with ERCP. Here we're dealing with post-cholecystectomy syndrome, in which there's recurrent constant abdominal pain and or dyspepsia that occurs months or years post-op. ERCP to evaluate the biliary tree can confirm diagnosis, for example, for a biliary stricture or a retained stone, and guide therapy. Okay. Question 137, a patient with a malignant gastric outlet obstruction gets a feeding tube. Now he has signs of hypophosphatemia, hypokalemia, and intermittent arrhythmias. What's the cause of this condition? Shows hypophosphatemia and hypokalemia. That's because of replenishment of nutrients, as opposed to hypermetabolic syndrome. That's in case of severe burns and sepsis, but in case of tumor lysis syndrome, there's replenishment of nutrients. We also see this in anorexia nervosa and malignancy. Question 138, a 2-year-old boy has intermittent abdominal pain and vomiting. Began several hours ago. Ultrasound of the abdomen is shown where we clearly see intussusception. What's the next step? So intussusception, we want to do an air enema, not necessarily urgent surgery, especially not as the first thing to do. We see the target sign in intussusception. And again, intussusception presents in children ages 6 to 36 months. Question 139, an 11-year-old girl has bright red stool since yesterday. Physical exam shows diffuse abdominal tenderness. Fecal testing is positive for blood. What is the diagnosis? So over here, this is another case of intussusception where we often see blood. Question 140, what is given to a patient with an acute GI bleed with hemoglobin less than 7? So we give packed red blood cells, not fresh flows in plasma. That's for severe coagulopathy, for example, DIC. Question 141, a 15-year-old boy has acute onset fever, abdominal pain, and leukocytosis. He has also vomiting and watery diarrhea. The abdominal pain used to be periumbilical, now it's right lower quadrant. There is no rebound or rigidity. The boy's younger brother also has diarrhea and abdominal pain. Is this an appendicitis? What's the diagnosis? No, it can't be appendicitis because here his brother also has it. Meaning, unless it was real on the test, they wouldn't tell you that. And he also has watery diarrhea. That's generally not also seen in appendicitis. This is actually pseudoappendicitis seen in Campylobacter infection. It's also seen in one of the other bacteria I'm blanking out right now. Maybe I'll remember it soon. But this is pseudoappendicitis. It's copying an appendicitis. Okay, question 142. Bowel obstruction in a patient with Crohn's disease is most likely due to, why would they get bowel obstruction? Fibrotic stricture. Stricture is a common complication of Crohn's disease from severe inflammation. Typically present with bilious vomiting, severe abdominal pain, high-pitched bowel sounds. Surgery may be required. Infliximab reduces inflammation in Crohn's, and adynamic ileus is when the small bowel motility is disrupted, for example, after surgery. 143. What is the first step in a patient with ALP equal 120? So it's really high, and signs of hyperbilirubinemia, but normal AST and ALT levels. So here we're dealing with a pattern of an abnormal liver function consistent with cholestasis. We want the first step would be an ultrasound. We want to get an ultrasound to assess hepatic, parenchyma, and biliary ducts. ERCP usually is done once we've already found a stone or a malignancy. Question 144. A post-op woman has 3 days of nausea and vomiting. She hasn't pooped or flatulated since the surgery. She's hemodynamically stable. X-ray is shown. In addition to fluids, what's the next step? So here she has what's known as prolonged postoperative ileus. Her bowels are just not moving, and therefore we want to get bowel rest. I should say bowel rest and serial exams. Bowel rest and serial exams. Again, it's typically self-resolves. Management is conservative. Question 145. A male who has anoreptive intercourse has an indurated erythematous mass near his oral orifice associated with severe continent pain and fever. So this sounds like an perianal abscess. What's the pathogenesis? How does it work? So it's an infected and occluded anal crypt gland. Question 146. A 62-year-old with a history of weight loss and fatigue presents, and the CAT scan of his liver is shown. What's the next step over here? So he has this, what's going on over here? So we want to get a colonoscopy. The colonoscopy, because we're concerned about colorectal cancer, because here we're not dealing with a primary liver lesion or a tumor, because that's usually not, it doesn't look like it's so scattered all over the place. This is metastatic, the most common location being the colon, because it dumps right into the drainage which goes to the liver. That's why there's metastatic cancer of the colon to the liver. Question 147, a 4-year-old boy has watery diarrhea for 2 days that becomes bloody on the 3rd day. So watery to bloody, that's seen in E. coli. The abdomen is diffusely tended without rebound. What's the diagnosis? Infection with E. coli, the Shiga toxin. It's watery, then bloody. Self-resolves within a week, but infection may be complicated by HUS after 1 to 2 weeks. You could take a look at the other choices for what they are associated with. Question 148, 57-year-old male has hepatomegaly, elevated liver transaminases, and a very high serum ferritin. Okay, this sounds very much like hemochromatosis. He would benefit from phlebotomy. As we mentioned, hemochromatosis is an autosomal recessive disorder caused by an HFE genetic mutation. There's increased intestinal iron absorption, and the diagnosis with HFE genetic mutation testing and treatment is with phlebotomy. Question 149. A 25-hour infant has not passed meconium. Sounds like cystic fibrosis. He has bilious emesis and dilated loops about on imaging. This baby most likely has cystic fibrosis. 90% of patients of such a presentation have cystic fibrosis. Question 150. A basketball player undergoes trauma to his abdomen, which is now distended and diffusely tender. Fast shows intraperitoneal free fluid, and the patient is tachycardic and hypotensive. So there's free fluid. What's the diagnosis? Duodenal hematoma wouldn't lead to free fluid. Pancreatic transection wouldn't really. It's a splenic laceration that's highly vasculated, therefore it could lead to hemorrhage, and a person will become hypotensive. Question 151. A woman who works at a daycare has loose, foul-smelling stools 5 times each day and night over the last 2 months. What's the next step? So they're day and night. When it's at night also, there's diarrhea. It's really concerning. We don't want to just go with the reassurance. We want to get stool antigen testing. For example, for Giardia, we would do SAT or PCR, stool antigen testing or PCR. Question 152. Average risk adults should undergo CRC screening beginning at age. So if they're average risk, what should they do? Age 45. High risk adults begin at age 40. Question 153. A patient has fever, leukocytosis, right upper quadrant pain. And here's a CAT scan of his liver. Ooh, look at that. He hasn't traveled recently. What should be done next? So here we're going to go with percutaneous aspiration in order to properly diagnose. There's a suspected pyogenic liver abscess. This is both diagnostic and therapeutic. Question 154. After undergoing Nissen fundoplication, the patient develops bloating, early satiety, postprandial emesis, and weight loss. What's the next step? We're going to go with the scintigraphic gastric emptying scan, because that is what happened over here in our situation is that there was vagal nerve damage during the Nissen fundoplication, which is a complication. And therefore the diagnosis with that is scintigraphic gastric emptying test, and management of the gastroparesis is with dietary modification, for example, small meals and low fat, and promethylate agents such as metoclopramide. Question 150. I did 154 again. Biliary atresia is best managed with Kasai procedures. Really interesting procedure. Liver biopsy in all suspected patients shows intrahepatic bile proliferation and portal tract inflammation. Question 155. After surgical resection of colon adenocarcinoma, colonoscopy screening involves 1 year post-surgery and thereafter every 3 to 5 years. Most patients with stage 1 colon adenocarcinoma are cured after resection. Some develop recurrent neoplastic colonic lesions, so they have to have the screening every 3 to 5 years. Question 156. A patient with chronic constipation has pain and rectal bleeding on defecation. Rectal exam shows a posterior mucosal tear of the anus. Besides stool softeners and cispets, what's the next best step? So here we have an anal fissure. So we want to go with topical lidocaine and nifedipine. Lidocaine is a topical anesthetic for the pain, and nifedipine is a vasodilator to increase blood flow to the anal sphincter to facilitate healing. All right, here we have a little bit more about anal fissures, and again, it's distal to the dentate line. Most are related to constipation. All right, and may be associated with a skin tag. Question 157, an elderly patient with episodic maroon-colored stools, not like these stools over here, but actual stools like feces, without associated abdominal or rectal pain or nausea vomiting. So they have these maroon-colored stools. Nothing was seen on colonoscopy several months earlier. What's going on? What is the most likely diagnosis? It's actually angiodysplasia, where there are dilated submucosal veins and AV malformations. That leads to this bleeding, which may not even be seen on colonoscopy. Question 158, a 49-year-old woman has chronic diarrhea, flushing, and a pounding sensation in her neck, weight loss, and a valvular heart disease with tricuspid regurgitation. If you recall from the earlier part of this video, this sounds very much like carcinoid syndrome. What's the most likely diagnosis? Carcinoid syndrome. Here we have the carcinoid tumors, which are well differentiated neuroendocrine tumors, and when they go with liver metastasis, it's known as a carcinoid syndrome. And the serotonin and histamine produced by the tumor are released into the systemic circulation, causing episodic flushing, which is seen in 85% of patients, and the other aforementioned symptoms. Question 159, steatorrhea in patients with chronic alcoholic pancreatitis is managed with alcohol cessation. And how do we teach steatorrhea in chronic alcoholic pancreatitis? We go with pancreatic enzyme supplementation. Question 160, what is the first line treatment for bile acid diarrhea? Cholestyramine. Do I have an explanation for this? Yes. So again, bile acid diarrhea is seen in 10%, about 10% of patients after cholecystectomy, as bile acid enters the small intestine more rapidly. So cholestyramine and these other bile acid resins, they bind the bile acid and prevent colonic irritation, and that's why they're used for bile acid diarrhea, as opposed to budesonide, that's for microscopic colitis, which is triggered by medications such as PPIs and NSAIDs. Question 161, an 18-month-old can't tolerate solids. He's not gaining weight. He suffers from eczema. What's most likely diagnosis? Eosinophilic esophagitis. That's what we have to look out for. We consider this in toddlers with poor feeding. bleeding, and the diagnosis with endoscopy and biopsy. Question 162, a 45-year-old woman presents with gradual onset fatigue, pruritus, elevated LP, hepatomegaly, and xanthelasma. What is the next step? So what are we doing over here? We want to, of course, check the antimitochondrial antibodies because this is a classic presentation of primary biliary cholangitis. Question 164, a 64-year-old man has postprandial abdominal pain and fecal occult blood is positive. Gastrointestinal shows a gastric ulcer. Biopsies are consistent with adenocarcinoma. What's the next step? So he's got this adenocarcinoma. What do we want to do now? We want to get a CAT scan of the abdomen. This is very important to get tumor staging at the time of the diagnosis for prognosis and treatment options. All right, which image represents Hirschsprung disease? So in Hirschsprung, we're going to see this. In this, we see dilated bowel loops and absent rectal air. There's going to be no air by the rectum. Okay, 165, a football player undergoes BAT, abdominal imaging shows free air in the retroperitoneum of the choices. Which was the most likely diagnosis? So stomach laceration, nah, that's not in the retroperitoneum, that's in the intraperitoneum. So pancreatitis due to trauma wouldn't happen that quickly. It's going to due to a duodenal tear. There's going to be air, as opposed to pancreatic due to trauma, there's going to be fluid. Question 166, a 37-year-old man has foul-smelling anal discharge and pruritus. There's no blood in the stool, but there's an indurated pustule-like lesion close to the anal verge. The patient has an episode of severe anal pain a few months ago, but it resolved in a few days, so this sounds like some sort of like real abscess or something, or a fistula. What's the next step? We want to go for surgery. This is an anorectal fistula. Here are different types of anorectal fistulas. We want to go for surgery. 167, a 29-year-old man has intense midline chest pain for several hours after vomiting for several hours. Chest x-ray shows widened mediastinum and a moderate pleural effusion. This sounds like a perforation leading to a pleural effusion. The pleural effusion fluid is yellow X-ray with high amylase coming from the esophagus. What's the diagnosis? That's an esophageal perforation. Really dangerous. All right, we want to can quickly progress to septic shock and death. 168, a 17-year-old boy develops scleral icterus after surgery. Indirect bilirubin levels are elevated, but LFTs are otherwise normal. This is consistent with Gilbert syndrome. It's benign, and it's due to UDP gluconyl-transferase deficiency. Everything's fine, no treatment. All right, question 169. An 11-year-old boy from Asia develops severe abdominal pain and signs of small bowel obstruction. He has no previous surgeries. Eosinophils are 15%, so we have some sort of helminth or something going on over here. What's the diagnosis? It's not adhesions. That's not really seen in kids, especially who have no surgeries. It's ascariasis, seen in people from Asia, Africa, and South America. It often is asymptomatic. It may have pulmonary or intestinal manifestations. It may cause small bowel obstruction, and the treatment for ascariasis is albendazole. Question 170, which vaccine should a patient with a history of intussusception not receive? Okay, so it's me, rotavirus. Because if they have a history of intussusception, rotavirus may induce another intussusception because rotavirus has a small risk of intussusception. We're not generally worried about it in the general population, but if a patient has had a history of intussusception, they should not get the rotavirus. Question 171, all patients with multiple lymphomas should be tested for. What's multiple lymphomas associated with? H. pylori. H. pylori played a major role in pathogenesis of this malt, and therefore they should get H. pylori. And they should get H. pylori eradication therapy if they're positive. Question 172, a 76-year-old male is being evaluated for iron deficiency anemia. A single fecal blood test is negative. He also has a systolic murmur at the right intercostal space with a normal S2. Sounds like a little bit of aortic stenosis. What's the most appropriate next step? Well, it's not severe aortic stenosis because he got a normal S2. So why does he have blood? We're going to go with endoscopy and colonoscopy to assess for the GI bleed. The aortic stenosis is not severe enough to lead to an occult bleed. 173, a 52-year-old woman undergoes colonoscopy. 2 small hyperplastic polyps are found and removed. The patient's mother developed colon cancer at age 81. It's not really a risk factor. What's the next step? Colonoscopy in 1 year, in 10 years? We want to go in 10 years. Because she has these small hyperplastic polyps, that's not really such a big deal. And the fact that her mother had colon cancer at age 81 is also not a big deal. It has to be less than 60 for it to be significant. Question 174, a 26-year-old woman comes to the ED with a worsening abdominal pain and intermittent vomiting for the last day. She has not had a bowel movement in a few days. Temperature is normal, blood pressure is low, her abdomen is distended with hyperactive bowel sounds. What is the most likely present in this patient's history? So she sounds like she has a small bowel obstruction. What's the most common cause of a small bowel obstruction? Stricture adhesions due to surgery, so she's likely had appendectomy. Question 175, a 35-year-old man presents with abdominal pain, distension, the following x-ray. Temperature is 90.6. What is the diagnosis? So this looks like volvulus. And over here, this is the cecal form. In the cecal form, it's when the cecal and the ascending colon twist on the mesentery can occur in younger patients, often due to a congenital mobile cecum. And here we have the difference between cecal and sigmoid. Cecal requires emergency surgery, resection of the volvulized colonic segment, and in sigmoid, volvulus management involves endoscopic detorsion. Okay, here is a difference between the cecal and the sigmoid. Cecal is generally in younger patients. It's less common. The sigmoid one is more common, and it's in older patients where we see the coffee bean sign. Management of C. diff, which has progressed to peritonitis, is, what do we want to do? We want to go with laparotomy. Amazing. It's a bacterial infection that leads to such a severe disease that you need to go for laparotomy. Over here, it could progress to infection, necrosis. We want to resect the diseased colon, perhaps. Just as a side point, C. diff risk factors include antibiotic use, but not only that, older age, gastric acid suppression such as PPIs, and less commonly IBD and cancer chemotherapy. So don't just think that the C. diff risk factors are antibiotics use. There are other risk factors also that may be tested on the exam. Question 177, subacute right upper quadrant pain, weight loss, signs of biliary obstruction, elevated CA19, and dilation of the intrahepatic or common bile ducts are seen in. So it's some form of tumor that's causing this obstruction. It's in cholangiocarcinoma. Right, in HCC, hepatocellular carcinoma, CA19 is rarely elevated. In cholangiocarcinoma, which is a highly lethal tumor, CA19 is going to be elevated. 78. A 77-year-old woman has progressive abdominal pain, nausea, vomiting, abdominal distension, high-pitched bowel sounds. X-ray shows distended loops of bowel with air fluid levels. She has never had abdominal surgery before, so she's had a small bowel obstruction, but she's never had surgery. There's fullness and tenderness within the right groin. Sounds like a hernia causing an obstruction. What's the diagnosis? Femoral hernia, common in females. Female femoral hernias can cause SBO. All right, question 179. Gross. A 56-year-old woman with a history of chronic constipation has horrible rectal pain that began yesterday. Rectal exam shows the following. What's the next step? So here, she has a thrombosed external hemorrhoid, which is severely excruciating painful. And in such a case, we go with hemorrhoidectomy, especially within 72 hours. After 72 hours, it will probably resolve on its own. But within 72 hours, we go with hemorrhoidectomy to relieve this excruciating pain. 180, an elderly man with a history of metastatic cancer and chronic constipation now has fecal incontinence. The abdomen is slightly distended. Vital signs are normal. What's the next step? So liquid is kind of making its way around the impaction. So here we check for fecal impaction. That could cause incontinence. All right, so I say over here. Question 181. This squirt sign is seen in Hirschsprung disease. That what happens is that they stick their finger in to the rectal vault, and that leads to expulsion of stool or gas due to temporary relief of the distal obstruction. So if you see the squirt sign on the exam, you know it's Hirschsprung. Question 182. A 2-day-old girl has abdominal distension and has not yet had a bowel movement. After imaging is taken, urgent laparoscopy is performed in which sticky stool is evacuated from the ileum. A sticky stool equals cystic fibrosis. What is the condition associated with nasal polyps that's seen in cystic fibrosis? Duodenal atresia is more with Down syndrome. Okay, question 183. Which marker in acute hepatitis correlates with an increased likelihood of mortality? So we want to see an increased likelihood of death, and that would be PT, because that means that the liver is not functioning properly, so much so that it's not producing the factors that it needs, right? Question 184, which will be abnormal first after acquiring HBV infection? So which will be acquired abnormal first? The surface antigen, that's the first thing. It measures the actual viral particles. The other choices measures the body's response. But the surface antigen measures the actual viral particles. Question 185, which indicates that a pregnant woman will transfer infection to her child? So we want to look for something that is transmissibility. E is all about transmissibility. That's the E antigen. Question 186, a 27-year-old woman falls during gymnastics and now has severe abdominal pain. On day 3, she has diffuse abdominal pain and nausea. The abdomen is thin and tender. X-ray is shown. So here we see it's diffuse and it's pretty much all over the place. This looks like paralytic ileus. What is the diagnosis? Paralytic ileus. So paralytic ileus is most common after abdominal surgery. It can also be seen in trauma. X-ray shows uniform dilation, gas-filled loops of bowel, and the treatment is bowel rest and supportive care. You can look at the other choices, what their associations are. Question 187, which of the following benign liver lesions grows with estrogen? Which grows with estrogen? Adenoma, estrogen. Hepatic adenoma grows with estrogen, may cause pain and a tiny risk of malignancy carried with it. Question 188, post-gastrectomy, a man develops nausea, diarrhea, cramps, and diaphoresis. What is the pathogenesis? He had his gastrectomy, now he's getting nauseous and has diarrhea. This is due to pyloric sphincter dysfunction. Pyloric dysfunction, dumping syndrome. That's a common post-gastrectomy complication occurring in up to 50 patients. So what happens is in this dysfunction, it leads to rapid emptying of hypertonic gastric content in the duodenum and small intestine, leading to fluid shift into the small intestine, leading to hypotension and stimulation of autonomic reflexes, and therefore dietary recommendations include small frequent meals, eating slowly, and avoiding simple sugars, increasing fiber and fluid between meals rather than during meals. Question 189, how is the colon adenocarcinoma that is metastasized to the liver treated? So it's metastasized to the liver. What do you do? Answer is just surgery. No chemo, just surgery. Liver is the most common location of colon cancer metastasis because the colon venous system drains directly into the portal circulation. We just go with surgery, not chemo. Question 190, a newborn has difficulty feeding, choking, as well as copious oral secretions. What is the next step? So copious oral secretions means we're dealing with a fistula. Nasogastric tube, in order to diagnose the tracheoesophageal fistula, is esophageal atresia, which is a congenital defect the patient has, is drooling. Question, and here we just have a picture of it on the right over here in C. Question 191, a 35-year-old Down syndrome patient who suddenly develops constipation should be evaluated for sudden thyroid function studies. It's sudden constipation. We're concerned that it might be an underlying hormonal abnormality. Question 192, what is the treatment for asymmetric sliding hiatal hernia? It's asymptomatic, which is found incidentally. Nothing. You don't treat it, you only treat it if it has symptoms. Question 193, bloating, flatulence, abdominal discomfort, and watery diarrhea in patients with ileocecal resection is consistent with? Well, in ileocecal resection, we remove that barrier from the colon and the small intestine, which prevents bacteria from going back. So if you have the ileocecal resection, there's going to be bacterial overgrowth, and that's what's exactly going on over here, small intestinal bacterial overgrowth. Another cause of small intestinal bacterial overgrowth can be motility disorders. But anyway, that is the point. And diagnosis with jejunal aspirate, that's the gold standard, or carbohydrate breath test to detect fermentation in the small bowel to indicate small intestinal bacterial overgrowth. Question 194, how is severe dehydration treated? This is with normal saline IV. Dextrose would be good for low blood sugar. And oral rehydration that's only for mild dehydration, but in severe dehydration, we want to get it IV. Question 195, fever, right upper quadrant pain, nausea, vomiting, air fluid levels in the gallbladder, gas in the gallbladder wall, and normal aminotransferase, that's emphysematous cholecystitis associated with Clostridium. Clostridium could cause that. Right? The treatment of choice is emergency cholecystectomy, along with broad-spectrum antibiotics, piperacillin, tazobactam, and bile culture. 196, what is seen in this CAT scan? Here we have a retroperitoneal hematoma. Hematoma, just keep that in mind in exam. You can, in the front of the psoas, you could have a retroperitoneal hematoma seen on CAT scan. Question 197, a patient has signs of small bowel obstruction, and the x-ray is shown. What is the next step? So here we see a free air, and that's really dangerous. We have to go with emergency surgery. We see the free air over there. Subdiaphragm free air indicates perforated viscous. Barium enema is contraindicated perforation, and an nasogastric tube is for decompressing a small bowel obstruction, but here we need to go intervene with surgery right away. Question 198, what should be done in a patient with epigastric abdominal pain, nausea, and elevated lipase, but no gallstones? So they have elevated lipase, but no gallstones. This is just like pancreatitis. We give IV fluids and supportive care, right? ERCP is for sphincterotomy and stone removal in patients with gallstone pancreatitis, or it could be used in case of malignancy, but here we're dealing with pancreatitis, acute pancreatitis that doesn't involve the gallstones. Question 199, a patient recovers from a cardiac arrest and is now asymptomatic. His aminotransfer levels are severely elevated. So he had cardiac arrest, and now he's asymptomatic, but his liver is problematic. What's the cause? Well, his liver got ischemia, hepatocyte ischemia. Necrosis occurs in zone 3, and poor prognosis in patients that do survive, the liver often recovers. Last question, how is pyloric stenosis diagnosed? Abdominal x-ray or ultrasound? It's going to be with the ultrasound. The ultrasound. A classic olive-shaped abdominal mass may be palpable. The ultrasound shows a thick and elongated pylorus, and the treatment is with pyloromyotomy. And that is the end of this review over here. I hope you enjoyed. Next coming up, I think, is going to be surgery. Stay tuned. Thank you for watching. Take care.